All right, so welcome to the lecture series. So we're diving into chapter 8, which again is one of my favorites because we get to talk about bones and their markings and their structure. All right, so let's go ahead and get into it. All right, so looking at the skeleton, it can be a little bit overwhelming because there are 206 bones that make up the adult skeleton. Now, you should know that you can essentially make a middle line between us. So we have equal sides. If you were to split us in half, we'd have two equal sides and we are symmetrical. So we're kind of mirror images of each other. So that just meaning that on what's on the left side of us, we have on the right side of us. So that kind of really cuts down the bones that we have to learn essentially in half. So that really makes it essentially about 53 bones on each side, just about. So that really cuts down half, or excuse me, 103 bones that we have to really learn. And we can actually cut that down a little bit more too. So bones are not that complex. So if we start from the top, of course, we have our skull, which is made of quite a few bones as well. But we start moving down. We can see that we have our vertebrae, which is going to make up our spine, which we have 7 in our cervical region, 12 in our thoracic, and then 5 in our lumbar. And then here we can see we have all of our ribs, which we have 24 ribs total, which if we have 12 on one side of us on the right side and 12 on the left side. So there we've knocked out quite a few bones. This bone up here, which is our clavicle, which we refer to as our collarbone. So if you feel on you, that's right there at the base of your neck. That is your collarbone, which that has a very specific job. And if that bone is broken, it takes a long time to heal, which we'll find out later in the series. In your top portion of your arm, this is going to be your humerus, which this is what people refer to as their funny bone. It's not spelled the same, but it does sound the same. They're homophones. So this is your humerus. And then these two bones in your forearm are your ulna and your radius. And then you have, of course, your hands. Here you have one of your coxal bones, if you remember back from the regions. Here, this region here is referred to as the femoral region because there's a femur in that region. Your kneecap would be your patella, which is the patella region. And then we have our tibia, and then the fibula, that's on the side, and then we have our foot. So that was just half of the body, and essentially we know that we have the exact same bones on the other half of the body. So in this chapter, we're going to actually dive into not only naming the bones, but also the structures that are found on these bones. So if we look here, we have different structures. So we have articulating surfaces, depressions, projections, and then openings and spaces. So this is a good chart that you might want to reference because it kind of categorizes all the markings that we're going to find in this chapter. So here I will actually demonstrate some of the structures that you see here in this chart. So with condyle, so condyle is a large, smooth, rounded oval structure. So we can see this is our femur. So this is the actual part that makes your hip. So this is when you put your hand on your hip, you're really not putting your hand on your hip. That's really not a structure. That's your iliac crest that you actually put your hand on. But this is your femur. So this is the top portion of your leg. This is right there. This is what makes up your thigh. This is the bone that's in your thigh. So at the end of it, that's going to articulate with our tibia, which is this bone here. So these two bones make up your entire leg, and your kneecap will go right here. So this bone, on the bottom of it, you have what's called a condyle. So if you may see that these smooth edges right here, these are large, smooth, rounded oval structures. These are articulating surfaces. Articulating just means that we have two bones coming together. And remember, we don't want our bones to rub up against each other. They need to be smooth. Bones tend to be kind of rough. So if you have two bones moving together, it'll kind of sound like this. And we really don't want that sound on the inside of us particularly. So these surfaces that are going to move with other bones have to be smooth. That's why they have hyaline cartilage on them. That was the point. Remember, hyaline cartilage was that smooth, glassy looking connective tissue. So usually all articulating surfaces that are with bones bones that are going to come in contact with other bones are going to have hyaline cartilage that's going to make it nice and smooth when it's coming in contact. So this would be a condyle. A facet would be a small, flat, shallow surface. So if we take a look here at our vertebrae, these are going to be facets. These are going to be those very small, shallow surfaces. This essentially is going to articulate, usually you're going to find these in the vertebrae. These are going to essentially sit on top of other bones. So it gives a nice smooth surface for it to actually articulate with. So a head, just like our head, it's a prominent rounded epiphyses. So remember, epiphyses are at the very ends of bones. So this is an epiphyses, and then this portion is an epiphyses. So here we can actually see that this portion right here is the head. So if this is the head, this is the neck, just like we have a head and have a neck. So it's a very prominent rounded portion. So this is referred to as a head. A trochlea is going to be a smooth grooved pulley-like process. So in our humerus, at the distal end of it, if you look here at the very base of it, this would be the trochlea. And this is only where we really kind of find the trochlea in or on our bones, is a pulley-like structure. This is going to actually act as essentially like a pulley for our elbow. So, fun fact, when you say you hit your funny bone, it's really not this bone that you're hitting. It's actually your ulna that attaches to it. So this is your ulna, which, hope you can see that. This is the only bone that actually has a U-shaped in it. So that's how you can always know that this is your ulna. So this portion of the ulna actually makes contact with the humerus. This portion right here is actually your elbow. So if you actually held it like an arm, so this would be your arm, this portion that you're actually hitting is the ulna. There's a nerve that runs along this, and so when you hit it, it feels funny. So that's why we always thought you were hitting your funny bone, but it's really not. You're really hitting this portion of your ulna. This is your elbow. So if you actually feel on your elbow, this is the bone that you're actually feeling on. So a fossa is a flattened or shallow depression. So, which I'll even show you the humerus again. So the humerus has this really shallow pit here. You can see my finger actually going into. This is a shallow pit or a shallow depression in bones. Usually we see fossas, usually fossa is going to have a muscle sitting in it. So when we get to the scapula, you'll see that it has different fossas, and usually that's where the muscle is going to sit. And actually, furthermore, when it comes to fossas and the muscles that are sitting in it, the name of the muscle will follow the name of the fossa. So pay close attention to the names of the fossas. A crest is a narrow, prominent bridge-like projection. So here's our coxal bone. So when you say you put your hand on your hip, you're actually putting your hand on this portion of the coxal bone. So this is not the hip. This portion right here is the hip socket, which is where our femur actually is going to attach and rotate. So your upper leg, your thigh, that bone actually articulates right here. So this portion is actually where this is the hip socket. You do not actually have a hip bone. This is the only thing that is called a hip is your hip socket, and this is where these two articulate. So when you put your hand on your hip, you're really not putting it on your hip. You're putting it on your iliac crest. So this portion right here is referred to as a crest. Crest is a narrow, prominent ridge-like projection. So maybe you can see it in the screen, but this is a ridge. So this bone is the iliac bone or the ilium. This ridge on top of it is the crest. So when you put your hand on your hip, you're not putting your hand on your hip, you're putting it on your iliac crest. A process is any marked bony prominence. So if we take a look here at our vertebrae, this portion right here, this pointy portion here, this is a process. So you can think of process as being this pointy, sticky, outy thing, right? So it's pointed, so it's a process. Anytime we see a bone that has a point on it, it's a process. The reason why they're a process is because this is where ligaments or muscles or tendons will attach. So essentially, they're going to attach like this so that it can hold on to something. So that's the only reason why we have a process is for something to stick onto. A trochanter, which anytime we use trochanter, it can only be on one particular bone, and that bone is going to be the femur. So these portions here, which I'll give you a better viewing of those, this portion right here and this portion right here on the femur are going to be the trochanters. So a trochanter is a massive rough projection that's only found on the femurs. This is where ligaments and tendons are going to attach so that they have a place. Anytime you see a rough portion on a bone, it is going to allow for attachment. So you kind of think about like how Velcro is, how one part is soft and one part is rough. So this would be the rough portion of it. So by it being rough, it gives ligaments a way to essentially attach without coming loose. A tubercle is close to a trochanter, but it's actually just a tad bit smaller. It's a smaller rounded projection. So if you look at our humerus, if you can see that on this end of the humerus, on this side of the head, this portion's a little rough. So I'll turn it this way for you. This part is a little rough. That is a tubercle. And then here's a tubercle on the front portion of the humerus. That's also going to allow for attachment of ligaments as well, ligaments and tendons. And then tuberosities are just a larger tubercle. You have a fissure. So if you look here, if you look in the eye sockets, which I'll hold up just a tad bit higher, there are these little slits that run in the eye. Those little bitty slits are fissures. How I've always thought about fissures is essentially fishes are kind of thin like this, and they can kind of swim into the fissure. So that's how you can always remember a fissure. They're very thin lines that are essentially thin enough that a fish could actually fit through. But fishes tend to be a little bit slender. And then foramen, which we tend to run into a lot of foramen. So foramen are going to be holes. So just like in the sacrum here, we have these holes in these bones. These holes are going to allow for blood vessels and more importantly, nerves to actually pass through. Some foramen have their own name, especially in the skull. So if we look at the bottom of the skull here, this is the foramen magnum. Magnum usually meaning big or very large. So this is a very large hole. So this particular foramen has its own name. But you can see underneath here, we have a lot more other foramens, which if I take you can actually see my hand running through here. So this is a foramen, this one be a foramen. All of these little holes that you're seeing here are foramens, which again is going to allow passageway of blood vessels and nerves. The meatus, it almost look like meatus, but it's meatus. A meatus is a passageway through a bone. So in the side of your skull here, where your ear canal would be, this would be your meatus. And this is the only place we really find a meatus that we'll probably talk about in here. But this little passageway is the passageway that's going to allow for your inner ear canal. So if you stick your hand, if you stick your finger in your ear, which make sure it's clean, but you'll actually feel the opening of your external acoustic meatus. And then a sinus is just a hollow space in the bone. So in our faces, we have two sinuses here, a few around our nose, and two right here in our cheeks. So the reason why we have sinuses is because, which we think of sinuses and allergies, but our sinuses are actually hollow spaces in our skull that's going to allow for our skull to actually be lighter in weight. If you think about it, when you're sick and your sinuses are stopped up, they're filled with mucus, and your head tends to feel a little bit heavier. Those sinuses, the tissue in those sinuses have essentially secreted mucus, and then they are inflamed, so that mucus can't drain, and so they kind of get trapped and it builds up. And mucus tends to be a little bit heavier. You can kind of think of your head as being about the weight of a bowling ball. So it's pretty heavy. So you have to have hollow spaces in your skull essentially to make your head lighter. But if they get filled with fluid, they tend to get a little bit heavier, especially when you get sick. And so that's why you kind of feel your head kind of feels a little bit heavier and you're kind of stopped up and you kind of feel eerie. You kind of have a pressure headache or a sinus headache is because those sinuses are now packed full and they're pushing on those nerves. And so you feel that. So those are the basics of bone markings and landmarks. So moving on, let's look at a few bones of the skull. So here we have our frontal bone, which it follows the region. It is our frontal region. So that one's pretty easy. We have our temporal bone, which is going to be on the side. So we have two temporals, which you can see on both sides. The sphenoid bone, which is purple here. So you can see in the orbital, the sphenoid bone, and you can also see it on this side over here. So actually the frontal bone, the parietal bones, the temporal bone, and the sphenoid bone, they all meet together over here on the side. And we'll see that in the next picture. The bone that's going to make your cheeks is going to be your zygomatic. The top portion of your jaw, which is right underneath your nose, is going to be your maxilla. The bridge of your nose, which is the very top portion of your nose, which even the part that you can touch is majority of that is cartilage, but there is a bone that's right there at the base, and we call it your nasal bone. So that one's pretty easy. You have the perpendicular plate that makes up the inner portion of your nose, and then you have the vomer. Now, you can't actually feel these unless you stick your finger in your nose and kind of deep inside your nose. So the portion that you can feel that's right here is actually called cartilage. So all of this that you feel on your nose is cartilage. However, that cartilage is attached to bone. The bottom portion of your chin, or the bone that makes up your chin, is going to be your mandible. And here we can see that we have mental foramen. So if you remember from our regions, this region was referred to as the mental region. So these foramen are going to allow for nerves to actually come through. So anytime that you go to the dentist and they're numbing your nerves, they're essentially targeting the nerves that run through here and also around your cheek. So you have facial nerves that's going to, I think you have two that runs right around here and one that's going to run at the bottom of your jaw. And so they innervate through these foramen. So here we can see we have foramen above the orbitals, which we should remember from the regions. These are orbitals. You have a supraorbital foramen. So supra meaning above. And then this is above the orbital. And then there's a foramen, which is a hole. So anytime there's a hole in a bone, it's usually referred to as a foramen. And again, they're for nerves, for nerve and blood vessel passage. So you have some above the orbitals. You have some below the orbital, which would be infra. So supra would be like superior. Infra would be inferior. So this would be infraorbital, which is below the orbitals. And then you have the two down here would be your mental foramen. The alveolar processes are essentially the processes that are going to allow your teeth, or essentially they are the sockets that your teeth fit in. Now, contrary to popular belief, teeth are not actually bones. They're actually they lack collagen. So if they lack collagen, they are not considered bone. So think about this. If I broke your bone, or if I broke your teeth, or broke a tooth, would it grow back tomorrow? No. Would it grow back in the next year? No. Bones regrow, but teeth do not. Teeth lack collagen, which is the cartilage or the tissue that is going to grow. So if it lacks collagen, they're unable to grow. So teeth are not considered bones. So here you can actually see an actual skull. You can see how everything is pretty well represented in the picture above. Now, when it comes to men and women, there's going to be a little bit differences in the supraorbital margins, as well as the occipital lobe of the skull. So if we look here, we see that we have the frontal bones, the parietal bones, and the occipital bone. But these are separated by sutures. So if we go back to the planes, we have the sagittal, we have the coronal, but for occipital, we have lambdoid. So I want you to think about it like this. Let's say if you're laying in a hammock, which a hammock is one of those swings you essentially tie to both to two trees, and it kind of swings back and forth. Usually, if people are laying in a hammock, they put their hands behind their head and they're relaxing in the hammock. So that's how you can remember laying in a hammock as in lambdoid suture. That lambdoid suture is going to be the suture between the parietal bones and the occipital bone. The sagittal, which is kind of like mid-sagittal, sagittal divides left to right. We can see that's in the middle of our skull. And then the coronal is going to be in the coronal plane. And we can see that over here as well. The temporal bone also has one as well, which this type of suture is a flat suture. So it's going to be squamal, just like it's a squamous, kind of like squamous cell. Squamous was that flat cell. This suture is a flat type of suture. So it gets the name of a squamal suture or squamous suture. Here, the pterion is where the parietal, frontal, sphenoid, and temporal bones are going to meet. This is very key, especially during fetal development, because there's going to be kind of a soft spot right here. So here we can see that we have a pointy, sticky outy thing, as I like to call it. So this is a styloid process. So you can think about some Samsung phones still have this. There's a styloid or a stylus that they can use to tap on the screen, kind of like an Apple Pen. So it kind of follows the same rule. It follows the rule of being a stylus. It looks like a stylus, but this is a styloid process. So remember, a process is going to allow for things to stick to it or bind to it. So part of the muscles in our neck and around our chin are going to have ligaments and muscles that are going to attach here. That's why it's kind of pointy, is for to be able to attach to it. Here we also have a mastoid process. This mastoid process is going to allow for muscles to attach to it. If you look, it's kind of rough looking. This is more smooth, but the bottom of here is a little bit rougher. This is going to also allow for attachment. So on our temporal region, on our temporal bone, we have what's called the zygomatic process. And this can get confusing because the zygomatic bone is over here, but the zygomatic process is here. So I want you to think about it like this. On the temporal bone, the process is pointing to the zygomatic, so it's the zygomatic process. On the zygomatic bone, it's pointing to the temporal bone, so this is the temporal process. So on the temporal bone, we have a zygomatic process, which is actually going towards the zygomatic bone. And on the zygomatic bone, we have a process going towards the temporal bone. Here we can see, we can get a better representation of our lacrimal bone, which is this green one that's right here. Now, it's called lacrimal bone, but also we have a gland that sits there called the lacrimal gland. That gland is what's going to produce our tears. So when you start crying, there's a gland that's right there up against that bone, right here at the very inner portion of our eye. That portion, that gland is called a lacrimal gland because it's right there at the lacrimal bone. So that lacrimal gland is going to produce your tears. So that's how you can remember lacrimal bone, because it's right here at the very base of your eye, and that's where you get your tears from. And then this pink one that's a little to the side is your ethmoid bone, which is going to, even though there's a little piece right here, there's a lot more that's back behind that. Also, your ethmoid bone is also going to be part of your palatine bone. So if you stick your tongue to the roof of your mouth, there's a hard portion and then there's a soft portion. That hard portion is actually bone, and it's the ethmoid bone, but more specifically, it's the palatine bone. That's going to be right there at the base of your mouth. And then once it starts going towards your throat, it gets a lot softer and a lot higher, so that when you swallow, that palatine bone helps crush your food and pack it into a bolus, and the softer portion allows for it to expand as it goes down your throat. There's also a lot of nerves that are running in that region too. So when you are having a brain freeze, they tell you to put your thumb up to your roof of your mouth. It's because it's essentially warming those nerves a little bit so that it can kind of reverse that brain freeze. So here you can actually see what it looks like on an actual skeleton. So here you can actually see all those bones fusing together at the pterion. And you can see all these different bones. It's a little bit harder to see on a regular skull. However, you can still see the sutures as well as the different bones, the styloid process and the mastoid processes and the occipital bone and the sutures. You can see everything that you can on the illustration. A little bit harder, but you can still see it. So here we can see our palatine bone. The ethmoid bone actually has the perpendicular plate, which is in our nose at the kind of the base of our nose, and the crista galli. The crista galli is going to hold our meninges in our brain. It is going to essentially anchor the meninges. Also, it's going to allow for the nerves or olfactory nerves of our nose to actually attach to as well. So, like I said earlier, this first portion of the roof of your mouth is going to be hard. And then the back portion is going to be softer. so it allows for you to pass your food through. So it allows your mouth to essentially expand when you're getting ready to swallow. So here's an inferior view of your palatine bone. And here you can also see your vomer, which is at the bottom portion of your nose. So here you can see a little bit more foramens and foramen ovale, foramen spinosum. This is where um, nerves are going to essentially come out of your skull and into your brain, or in this case, the cervical region. Now, it's important that these holes do not get jammed or closed because you have the passage of blood vessels and nerves running through there. If they were to get closed, or they would start getting tight around nerves, you essentially have pinching of nerves or loss of blood flow, and that could lead to a lot of different issues. So here you can actually see the crista galli from an superior view. This is what's going to allow your meninges to attach, which are in your brain, that's going to attach to that portion. Now, the sphenoid bone, which is the bone that we saw that was on the side of the eye and the inner portion of the eye, here you can actually see the superior view of this, and it continues to go inside the skull. So it has, I believe they refer to them as wings. So the greater wing of the sphenoid, and then you have a lesser wing. So it kind of actually, this really looks like a bird if you look at it. This be its beak, its head, and its wings. So this is essentially how you can remember the sphenoid bone. It looks like a actual bird. And then here you can see your temporals, and then your parietals, and then your occipital bone. So there are some disorders that can happen. So this right here is referred to as cleft lip. So essentially during development, the palatine bone actually does not form correctly. And so the tissues actually kind of essentially get caught in this formation, and it causes a cleft lip. This is a more severe case of a cleft lip. So it can be due to genetics, but usually it's a birth defect of some sort. And so essentially that palatine bone does not form properly. And so essentially you can see here that portion of the lip is actually intertwined in that palate. So this can be corrected by surgery, which I know a few people in my lifetime who has had a cleft lip. And so essentially they have to go and cut, and they have to reconstruct this portion. And usually there's usually a scar that runs down. And eventually over time it does fade. But this is a birth defect. Here is another type of disorder. So that was cleft lip. Here's a cleft palate. So the palatine bone actually does not form properly. And essentially you have a hole in the back of your throat. So you might not have noticed that your nose and your throat are actually connected to one another. However, if you have a hole in the back of your throat, food that you eat or potentially drink can essentially go to the back into this hole and actually come out of your nose. So usually there is kind of like a filter that for air that comes in, for things that come into your nose, it kind of already goes straight down the back of your throat. However, you now have a access to that, which so essentially if you drink something and instead of it going down your throat, it can accidentally come out your nose. If you kind of swallow, if you when you swallow, it will essentially half of it to go down and half of it to kind of go back out your nose. So that could be really problematic. That can also cause things to go down your lungs that are not supposed to. So these are defects that can be surgically altered and fixed, but it takes time. So here are the actual sinuses. Here you can actually see, here is your maxillary sinus, which is called maxillary because it's on your maxilla. So these are your sinuses. Here's a frontal sinus that's at the top of your, or actually right in between your eyes. And then you have your ethmoid sinus, which is by your ethmoid bone. So these are your sinuses. Remember, sinuses are just empty spaces. Typically when we think of sinuses, this is when we're getting sick and we say our sinuses are acting up. If you look more closely, these sinuses have tissue that line the inside. That tissue can sometimes get inflamed with a pathogen or mucus, and essentially it doesn't allow that mucus to drain. And these pockets that are supposed to have air in them start filling up with mucus. And when it starts filling with mucus, your head gets heavier. So that's why your head gets so heavy when your sinuses are filling up with mucus. Also, you have what's called a sinus headache. Essentially, these are supposed to be filled up with air, and now they are filled up with fluid, which puts a lot of pressure on these tissues. And then, so that's what you're feeling is all that filled up. So here are some other disorders. So this is sagittal synostosis. So essentially, the sagittal portion of their brain either fused or did not fuse properly. And so now you can actually see their head essentially starting to grow through its elongation or through the sagittal plane. Here we have coronal syntosis, which essentially the head starts growing kind of sideways, so your head kind of becomes a little bit bigger. Also, this is one reason why they tell you not to lay kids on the back of their head or on a certain portion of their head for too long. The the bones of the skull, which they're not completely formed yet because they're still developing, those are really, really soft. They're more like cartilage than anything. And so if you lay them on their head for too long, in a certain position, it can cause that portion of their head to actually flatten. Sometimes during childbirth, sometimes they have to use a suction cone to help pull the head out of the canal. And sometimes the head can look like a cone head, essentially. So their bones are not really bones yet, they're cartilage. So they're easily manipulated and they can essentially they can take on the shape that they either lay on or that is around their head. Sometimes children have to wear helmets, depends on their head shape, so that their skull starts forming properly. And here's just a better representation of your sinuses and where they're connecting. Here you can actually see how they drain into your nose and from your eye. So that's why when you have sinus and allergies, usually you feel that pressure right here around your nose. So your hyoid bone, which is a very interesting bone, this is the only bone, which hopefully you can see, this is the only bone that does not articulate with any other bone. So in layman's terms, this bone is not attached to any other bones. It's kind of free floating. This bone is the attachment site for your tongue. So the purpose of having bones is for muscle attachment so that our muscles can move or that you can move. In this case, the hyoid bone is going to allow for attachment of your tongue. So your tongue is actually attached to this bone. If you feel on your top base of your neck, you have to kind of stick your fingers really deep in there, but you can actually move it around. This bone is right above your larynx. This is your voice box. So if you feel out where your Adam's apple is, and even if you're a woman, you have an Adam's apple, it's just not as prominent as men's are due to testosterone. However, on your larynx, if you just go up a little bit, the very base of it is your hyoid bone. Now, also, when it comes to if you like crime shows and you see people get strangled to death or if they commit or they unalive themselves, usually by hanging. If you were to strangle someone, not telling you to strangle someone, but if you were to strangle someone, if someone was strangled, this bone would break. You have to use a lot of pressure and a lot of strength to break this bone. But usually, if you are strangling someone, this bone has to break. However, if you were to unalive yourself by hanging, this bone would not break. So in homicides, if this bone is broken, usually that's indicative of a homicide or someone was strangled. If someone tries to cover up that homicide and try to make it look like suicide and this bone is broken, that is indicative that this person was strangled and not um, self-inflicted. So this bone is really interesting is because it has a good portion to do with how you talk, well, kind of how you talk of the structure of your larynx, but it also has something to do with your strangulation as well. So that's just one fun fact about that particular bone. So for determining male and female, which I understand in this day and age that there are more identities, but in this case, we're just referring to male and female. So there's some different shapes or signs that we can look at and determine if this is a male or female. So for this case, we have the supraorbital margin. So if we compare these two, this one is a very thin and sharp versus this one is a little bit more blunt. So it's kind of hard to see, but if you look closely at the male, these these orbitals stick out just a tad bit more. It's kind of like a porch. It kind of actually kind of sticks out above a little bit more. You can see how deep it is if you look at the notches. So let's take a little bit better look. So here we can see that this one, you can actually, this one's more of a hole. This one's more of a notch. This supraorbital margin is thicker. It comes off a little bit more off the skull. This one, it hardly ever comes off the skull. It really just kind of looks flush with the skull. But this one kind of looks like a little porch, like you have a little porch on the edges of your skull. If we look at the lateral view, if we look at the back of the head right here for females versus male, male is a lot more blunt. It's a lot more flatter, and the angle, it makes a real sharp angle. Females are a little bit more curved, and it's not as harsh of a curve, but this one is. Also, let's look at the top. So for females, it's a lot more vertical. This one for male is a lot more sloping. Also, you may notice that females are going to be nice and kind of even on the top. There's not a big spike. However, here we see that there's a large incline. So males have a lot more angles. Women are a little bit more smoother and they're not as wide per se, but males, they have a lot more sharper angles. So for babies or fetuses or small children or infants, they have what's called our soft spots. So here we can actually see that these are they're not referred to as soft spots, they're actually referred to as fontanelles. That's the actual medical term for it. But we have fontanelles in the places where bones of the skull are going to meet. So remember, the infant or the child's head is still developing, so it has to be able to expand. The reason why these are not attached is because if they were attached, the brain would not be able to essentially expand and get bigger. So they have to have what's called soft spots, which is going to be very thin membranous cartilage or tissue that's going to allow for stretching of the cranium. And once it gets to a certain age, they will ossify and become bones. But this is the reason why we have sutures, is because all these bones will essentially fuse together over time, but they have to be separated so that the child's brain can grow. So you have the anterior fontanelle, which anterior means the front, sphenoidal fontanelle, which is where our sphenoid bone is. We have the mastoid fontanelle, which that's where our mastoid process is going to be on the occipital bone. You have the posterior fontanelle, which you can see a better view right here. And all these fontanelles are going to be pretty spacious. In children, sometimes you can actually, it's not really good to press on them, but if you were to palpate them, you can actually feel, sometimes you can actually see them kind of bulging a little bit because there's a little bit of a blood supply there. But again, do not press on these. These are very sensitive portions of the skull, which can affect the growth of that skull. So be very, very careful when dealing with an infant's head. So the vertebral column, so there are quite a few vertebrae. However, these are pretty easy to remember. So in the cervical portion, we have 7 different bones or 7 vertebrae. In the thoracic region, we have 12. And in the lumbar, we have 5. So a way to remember how many bones are in, the vertebrae. So think about it like this. So think about it as for like the times that we would eat. So 7 in the morning would be breakfast, 12 would be lunch, and then 5 would be dinner, which I know we don't really eat dinner around 5, but that's just a way to remember how many vertebrae are in each region. So in the cervical, we have 7. In the thoracic, we have 12 vertebrae. And in the lumbar, we have 5 vertebrae. So the way that these are numbered is by the number that it follows. So the very first cervical vertebrae, which is C1, is going to be, well, the first one is C1. The second vertebrae in the cervical region is C2. And it goes on C3, 4, 5, 6, and 7. The C stands for cervical. So if I say C2, that's going to be the second bone in the cervical region. If I say C5, that's going to be the 5th bone in the cervical region. That follows suit for the rest of them. So in the thoracic region, that's one reason why it's referred to as T1 through T12. So all these vertebrae in the T region or in the thoracic region, they'll start with a T. So the first vertebrae in the thoracic region will be T1. The second would be T2, T3, T4, all the way to T12. So if we say T7, that's going to be the 7th bone or the 7th vertebrae that is in the thoracic region. So we just count down, and this would be T7. Same thing for lumbar. The very first one in lumbar will be L1, L standing for lumbar. You have L1, 2, L3, L4, L5. Now, in the sacrum we refer to as one bone, but that bone used to be 5 different bones. So that's why they have it S1, S2, S3, S4, S5. However, once we get to a certain age, all these vertebrae in the sacrum fuse together, which fuse just means that they go from many to one. And so we get this. This would be our sacrum. So we tend to count this as one bone once we become adults, but it used to be 5 different bones. That's why there's 5 different holes, because these used to be vertebrae and then they fuse. the coccyx, which is the tailbone at the very end. And we call it a tailbone because it is a tailbone. So the tailbone actually was four different bones. And as we are developing in the womb, it actually shrinks down and it becomes these four little bones. And then they fuse together and become one bone that we call our tailbone. Now, does that mean that we're monkeys? No. That just means that we had a common ancestor that essentially had a tail. But it's a vestigial bone at this point because we don't actually wag our tails anymore. We don't have tails anymore. It's actually believed that the muscles in the pelvis and the floor of the pelvis actually used to be muscles to allow for moving our tails. But again, we have not had tails in probably hundreds of thousands of years. So we are not monkeys. Let me clarify, we are not monkeys, but we do have a tailbone. So here are some different types of disorders or abnormalities that come with our backs. So I actually suffer from scoliosis. So my back makes an S-shaped structure. Um, there's probably a few reasons for this. Is one, because I always carried a backpack on this side of my shoulder. And so it kind of over time, it essentially it pushes down on this side and it raises this side. So it kind of affects your back. On top of that, my feet now, when usually I can tell that a person has scoliosis, if you look at their shoes, they kind of walk on the insides of their shoes, depends on how their scoliosis runs. Also, because your clavicles and your ribs are essentially attached to your vertebrae, which you can kind of see in the video here, my right shoulder kind of dips a little bit. And so I'm always constantly popping my arm is because it has shifted the weight of my pectoral girdle, which is where my scapulas and my arms are. It just kind of shifts it like this. So this arm tends to always fall out of almost socket a little bit. You have to pop it back in. There's really no cure for it, really, except for just exercising and trying to get those muscles back into shape. Um, so that's the only thing that can really fix this issue here. For women who are pregnant, they go through lordosis or hyperlordosis. Um, so with scoliosis, it makes an S shaped, but with lordosis, it makes like a backwards L. So that's how I can remember lordosis. And usually that's usually with pregnant women because they have all that weight on their stomach. So it's pulling their front out. And so essentially the back essentially kind of trying to catch up with that weight, essentially. Hyperkyphosis is hunchback. Typically, we usually see this in older people. This is one reason why this was done purposefully. Usually, we see this in older elderly people, and that's usually because the ligaments have become weaker. And so, you remember, your head is kind of like a bowling ball. So it will essentially, over time, essentially pull down, and so it pulls your back up because your head essentially is weighing down on your head or weighing down on your neck. So with the vertebrae, they have different processes. So the very edge or the part that you can actually feel when you run your finger down your back is the spinous process, which is this portion right here. Now, you also have another type of process, which are the transverse processes. If you remember from the regions and planes, transverse was like this that goes across. So here we can see that this is in the transverse plane. So these are the transverse processes. Here are the facets, which are going to essentially allow for other bones to articulate or the ribs to articulate. This is where they're going to attach. This is the body of the vertebrae. This is what's going to stack on top of each other. So each vertebrae has a body, and there's going to be fibrocartilage are those cushion cartilages that are going to sit on top of here to keep these bones from contacting each other. So if you look here, we can actually kind of see, which I'll put in the camera for you. This in the middle here is the fibrocartilage that's going to sit between those vertebrae. So here's the vertebrae here, here's a vertebrae here, and in the middle we have a fibrocartilage. That's going to allow for compression between those vertebrae. Now, fun fact is that when you do a lot of walking, these fibrocartilages actually get compressed a lot. So actually your height actually shrinks. So after I do a lot of walking, I go from 6'3" to about 6'2" or 6'1". So all that walking, all that weight on your body will compress all of these and essentially makes you shorter. So there's three different, which in the lab videos I'll talk about, there's three different types of vertebrae. So depends on if you look like a giraffe, that's your thoracic region. If you look like a moose, that's going to be your lumbar region. So we can tell by the different um, landmarks or by the body. Typically, I can tell that this is a thoracic because it makes a T-shaped, but also the body is medium sized. The lumbar tends to be a lot bigger, which because the lumbar is at the base of the back, it's at the lower of the back, it holds a lot of weight. So the body in the lumbar is going to be bigger than the thoracic. The cervical, which is at the base of the neck, the cervical is kind of about half this size. And then as you get down, as you go lower down the spine, the body of the vertebrae get bigger. And then as you get to the lumbar, they get even bigger because they're holding all of your weight from everything from your head to your waist. The lumbar carries a lot of weight. That's usually one reason why people who have lower back issues is because that lower back carries so much weight. And so here you can actually see how these stack on top of each other. So here we have the vertebral foramen. So vertebral is referring to the vertebrae. And this is a hole in a bone. So this is, of course, a foramen. So here, the spinal cord will actually pass through. So the spinal cord will go from the base of actually from the foramen magnum of the skull, and it goes straight down the middle of your back, and it goes through these holes in your back. So if one of these vertebrae were to move, it can potentially cause some pain to happen with your back. Along with that, you have what's called intervertebral foramen, which inter means in between. And so this is referring to in between the vertebrals or the vertebrae. So essentially, this is looking at the spine or the vertebrae from the side. Up here, we're looking at it. This is from the back portion. This is if you're standing over the top of the vertebrae. But this is the side where we're going to see spinal cords come out of. So you can actually see it here. Here you have the spinal cord going down the middle, but on the sides you can see that there are spinal cords coming out the sides of the spinal cord of the vertebrae. You can have what's called a herniated disc, which that just meaning if you are compressing those discs in between those vertebrae to the point to where it starts to bulge out. So it's kind of like you have a balloon in between a vertebrae and you're squeezing it so much that it's getting ready to pop. That's what's referred to as a herniated disc. So you can see right here, this is a transverse cut of the vertebrae. And you can see that right here, that there is a bulging of this disc. That disc is supposed to be straight across like this. However, there's so much pressure that it's pushing into the spinal cord. This can cause a lot of issues and a lot of pain if it squeezes too much onto this nerve, or even if it was to rupture or burst open, that fibrocartilage is filled with kind of like a fluid or a gel-like fluid. If that was to burst open, it's not going to be able to allow for the bones to have cushion. It's going to flatten out and can potentially cause degeneration of this fibrocartilage. So now eventually you'll end up having bone rubbing on bone every time you walk. This can be very, 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 very painful. So here we see a cervical vertebrae, which is at the very base. And we can see how the spinous processes, it's a bifid spinous process, which bifid means that it looks like it has two fins on the vertebrae on the spinous process. This is the only vertebrae that actually, portion of the vertebrae that actually has the foramens on the side. The transverse foramens are on the side of the vertebrae. If we look at the thoracic region kind of makes a T-shaped, but it also makes a giraffe shape too. Here we can see the body is a tad bit bigger than the cervical region. This vertebral region is going to be where your spinal cord is actually going to go through. And this is just giving you the side views of those. So these would be essentially, when these stack on top of each other, this would be your intra foramen. All right, so one of the most important foramen that are going to be, or vertebrae that you're going to have, is going to be going to be the very first ones of your cervical region. So C1, or the very first vertebrae in the cervical region, is going to be referred to as your atlas. This is also known as C1. So you can see this, you'll see it as two different names. You'll see it either as C1 or as the atlas. So this bone here is responsible for you to be able to turn your neck left to right and up and down. This is the only bone that is in the vertebrae that is going to allow or that actually moves at all. There's no other bone in your vertebrae that is going to move. C1 is the only one that actually moves. The way it's able to move is with C1 and C2. C2 is actually this bone right here. It's also known as your axis. The axis has a process on it referred to as the dens. Sometimes it's also referred to as the odontoid process. This is going to act as an axis or a guide for the atlas. So if we look down here, the atlas, which is C1, is going to sit on top of C2. It's going to allow for the atlas to move left to right and up and down. So if we take a look here, so here is the dens, which you can see, here's the dens right here. So this is C2. C1 is going to sit on top of it like this. By this bump, this is when you shake your head, you're actually moving C1 back and forth. However, if you were in a car wreck, which I hope you understand that your spinal cord runs down the middle of this. So where I'm sticking my finger through is where your spinal cord would run. If you were to get in a car wreck and you were to break this process, the dens right here, and this were to break, it will go across your spinal cord and sever it, also known as internal decapitation. So C1 and C2 have a very important job. which is what's going to allow you to move your neck left and right and up and down. This is the only bone that's going to move in your vertebrae. All the other ones are going to stay nice and stacked on top of each other. If they don't, you have to go essentially to a chiropractor, which honestly I would recommend, especially if you have a lot of migraines, things of that nature. If we A chiropractor will adjust your vertebrae to be back in line, which will essentially it can cause the vertebrae to go back into line, which would alleviate a lot of pain. And sometimes a lot of different illnesses can actually be stemmed from your vertebrae not being in line. I had a student in the past who had chronic migraines. And so I told her to go to the chiropractor, and they finally readjusted her neck, um, and it actually stopped her migraines. So sometimes by vertebrae being out of place, it can cause a lot of pinching on nerves, which can start affecting different things. It can actually um, if your vertebrae are not in line, they can actually cause you to have a lot of tingling in different places. It can cause you to lose function in some of your arms or in your limbs. So it's important that you do once in a while at least go to the chiropractor. So again, this is our sacrum. So we have S1, S2, S3, S4, and S5. Those bones all do fuse together and become one, which is referred to as the sacrum. So as children, we actually have a lot more bones than adults. However, eventually, as we get older, these bones are going to fuse and become one. Now, for the coccyx, especially in women, during childbirth, you can actually break this bone. Sometimes pushing up through the canal, you can actually cause the coccyx to break or dislocate, and that can be very painful. So the treatment for that would be essentially um, ibuprofen, ice, and they essentially give you this donut to kind of sit on, so that you don't sit flat on your butt, and keeps the pressure off your coccyx. But typically, that's usually commonly broken in childbirth. Depends on how big that child is. Usually, it's going to break it or dislocate that coccyx. So now we've gotten down to the thoracic cage. So remember, in the thoracic region is our chest. So if you remember at the beginning, I said that the thoracic cage or your ribs, you have 12 on each side. So that's 24 bones right there. So you have what's called true ribs and then false ribs. So true ribs are your first seven. So the first seven, 1, 2, 3, 4, 5, 6, and 7, they have labeled in blue. The reason why they're called true ribs is because they actually have their own cartilage. So remember that we have hyaline and fibrocartilage, and each rib is attached to the sternum by a single piece of cartilage. That's what you see here in white. However, our false ribs, which are 8 through 12, if we look closely at 8, 9, 10, we can see how these three ribs, they are attached to a cartilage, but those three cartilages essentially merge into one cartilage. So for 8, 9, and 10, we see that they all merge into one cartilage, and then they attach to the cartilage of 7. So that's why 8, 9, and 10 are false. The last two, which are 11 and 12, are floating ribs. They don't have any cartilage at all. You can see right here with 12 and 11, they essentially end and they don't have any cartilage. Those are referred to as your floating ribs. So the false ribs are composed of 8, 9, 10, 11, and 12. Even though 8, 9, and 10 have a cartilage, they merge into one cartilage. And then 11 and 12 are just floating ribs. So false ribs are going to be from 8 to 12. And then your true ribs are 1 to 7. Now, we usually refer to this as the sternum, which this is also the sternal region if you go back to chapter 1. But the sternum is actually made up of 3 bones. We have the manubrium, the body, and then the xiphoid process. Remember, a process has a sticky outy point on it. So here we the xiphoid process. Sometimes during bone development, sometimes the ossification centers don't operate properly, and they essentially leave a hole in the sternum. That's only I think every 1 to 2,000 people get it, or 1 to 1,200 people get it. And sometimes it can be mistaken as a bullet hole in autopsies, but that's really just a hole that kind of gets left behind and forgets to close up. But the sternum is not just the sternum, it's made up of 3 different bones: manubrium, body, and the xiphoid process. Each rib, if you notice that there was 12 ribs, well, in the vertebrae, and the thoracic vertebrae, as this is the thoracic cage, each rib is attached to the vertebrae. So each vertebrae in the thoracic region has a rib attached to it. So thoracic 1 has 2 ribs attached to it, for 1 for each side. So all the thoracic regions, they have those facets that allow for articulation with the ribs. So T1 through T12 have ribs on the vertebrae. And here you can actually see how they actually attach. You can see that those facets are where the rib is going to attach, and then those transverse processes are going to help hold the shafts of the ribs above. All right, the pectoral girdle, which is essentially that articulates with the trunk and supports the upper limbs. So you may have heard me say at the very beginning that the clavicle or the collarbone has a very important job. So if you look at this picture here, the clavicle that's right here is what's holding up your arm and your scapula. That collarbone is the only bone that holds your arm to your body. Your entire arms, the only bone that's going to hold that together or that's going to articulate that to your body is your collarbone. So if you break your collarbone, there's one reason why they had to put you in a sling is because that collarbone is responsible for holding all of this weight. If you break that collarbone, you're going to have a long time to recovery, but you're also going to have to put it in a sling because for it to heal properly, you can't put any weight on it. So the collarbone is responsible for holding all this together. So if we take a look at the collarbone or the clavicle, we have what's called the sternal end and then the acromial end. The sternal end is going to actually articulate with the sternum. So here you can actually see how it's going to articulate with the sternal or the manubrium more specifically. So this end of the sternal, or this end of the clavicle, which is the sternal end, it's called the sternal end because it actually articulates with the sternum. The acromial end is going to attach or articulate with the acromion on the scapula. And here we can actually see the scapula here and how it's going to actually attach or articulate. So here's a better representation of our scapulas. So here's another landmark called the spine of the scapula. This is very important because this is going to help us determine if this is left or right. And yes, you will be asked if this is a left or right one. So if we look here, if we take the spine and let's treat this spine in acromion as an arrow. What direction is this pointing? It's pointing to the right. So this is the right scapula, which it confirms that for us down here. But to find if something is left or right for the scapula, just look at the spine and see which way it's pointing. This view of the scapula is if I was standing behind someone looking at their shoulder blade. If I'm standing behind someone, this is what their right scapula will look like. So this fossa that's right here, which remember a fossa is a shallow indention. This fossa is above the spine, which this is the spine here. So if it's above the spine, it's going to be the supraspinous fossa or spinatus. So this is supraspinous fossa. So if we're below it, so if supra means superior, inferior would be below, but in this case it's infraspinous fossa. So this fossa is above the spine. This fossa is below the spine. The acromion is going to be the flat piece that's going to articulate with the acromial end of the clavicle. That's one reason why it's called the acromial end, is because it articulates with this. Over here, which is the same one that's here, it's flipping it around. This is the coracoid process. This one to me kind of looks like a bird. If you look at it from this viewpoint, it looks like a bird. So I always think of caw, caw. It's coracoid. That's how I've always remembered it. This portion right here is referred to as the glenoid cavity. Sometimes you may see as the glenoid fossa, which is where the head of the humerus is going to articulate. So the very base of our arm that's attached to our shoulder, that's our humerus. This is what makes up our shoulder. This is where our humerus is going to attach. On the back side of the scapula, we have the subscapular fossa. So on the back of it, we have the supraspinous and the infraspinous. But on the back of it, we have the subscapularis, which sub means below. Now, when we get to the muscle chapter, we're going to see that the muscle that sits right here is going to be the supraspinatus and then the infraspinatus. They're named after the fossas. Now, looking here, we have the lateral border and medial border. Remember, medial means midline, lateral means further from the midline. So if we look here, this is our right scapula. The middle or the medial line would be running where our vertebrae is. So this is the medial border because it's closer to the midline. This is the lateral border because it's further from the midline. How I can always remember these is because my armpit is lateral. This actually makes up the armpit. So this little curvature right here, if you follow the curvature of your armpit, it follows the curvature. So I know that's lateral, that's going further from my midline. The medial portion is going to be facing the midline or my spine. So the humerus, it kind of looks a little similar to the femur. It has a head, which this white portion is the articulated surface. So this is hyaline cartilage, which is going to allow for nice articulation with the glenoid cavity, which we just saw in the scapula. This little rough edge right here is going to be called the greater tubercle. So the greater tubercle or even greater trochanter are always going to be lateral. The lesser tubercle is always going to be medial. So you can kind of think about this like a head and neck. So you have the head, just like we do. You have the neck, like we do. To the lateral portion of us, we have our ear, which would be our greater tubercle. Medial would be our nose. So this would be your head, neck, nose, and ear. That's how you can think about it. So head, of course, our neck, which is right underneath. Our ear would be the greater tubercle, and then our nose would be the lesser tubercle. So if you may see over here, we have a anatomical neck, which would be like our neck. But here you have the surgical neck. The surgical neck is essentially where you would most likely have surgery, because if you were having issues with this is where we would cut off this bone and replace it with a prosthetic or some type of artificial head of your humerus. So the surgical neck is where we would cut and essentially replace it. The anatomical neck is the actual neck of the humerus because it's right underneath the head. Here along the shaft, we have the deltoid tuberosity. Tuberosity is just a rough little, I call it like a little bump, but it's a little rough edge. This is where the deltoid is going to attach or insert itself. So remember, the deltoid region was in our shoulder, right? Well, remember, this is the bone that makes up our shoulder, so the muscle has to have a place to attach. So the deltoid tuberosity is where our deltoid muscle is going to attach. Here we see we have a radial groove, which is where the radius is going to essentially be kind of snuggled with, or kind of snuggled with the humerus. At the base of our humerus, we have on the back side, on the posterior view, we have the olecranon fossa. If we remember from the regions, this was the olecranial region, and there is a reason why. The olecranial fossa is going to be where the ulna, where the olecranon process of the ulna is going to articulate. On the front of it, we have a coronoid fossa, not to be confused with coracoid fossa. The way I remember coronoid fossa is usually because with my students, I get annoyed that they don't find it humorous. So usually when I tell a joke, I'm annoyed that my students don't find it humorous. So coronoid, like annoyed, coronoid fossa is found on the humerus. Coracoid, like caca, is found on the scapula because it looks like a bird. Here we have the trochlea, which is the pulley-like portion, which is what's going to articulate with the ulna. The capitulum is going to articulate with the radius. If we look at a radius head, the very top of the head has this little bitty divot on top of it. The divot is going to articulate with the capitulum. Now with epicondyles, epi means closer to the surface. So how I always think about the condyles, everything points medially. So I always tell my students to take their hands and put their thumbs, make a fist, put their thumbs out, and put it in front of you, kind of like this. This is how you can tell the humerus left and right. So if you're looking at the one on the right-hand side over here, that epicondyle would represent our thumb. So it's pointing towards the midline on the right side. So that's how we know that it is our right humerus. So just mimic the hand gestures with the actual epicondyles. So if you're looking at this epicondyle, we see that this epicondyle is pointing to the left. Which one of your hands has your thumb pointing to the left? That would be your right hand. So that's how you can tell if this is the right or left humerus. The epicondyle is pointing to the left. You stick your arms out. Your thumb is pointing to the left with on your right hand. So this is your right humerus. So here we can actually see how our ulna and our radius is going to articulate with the humerus. The capitulum is kind of this rounded pebble-looking shape. The radius has this little bit of a shallow indention which is going to allow for the capitulum to essentially be nice and seated with the radius. The ulna, remember, it makes this U-shaped structure here. So this U-shaped structure, it acts as a hinge, which is going to allow it to rotate back and forth. That's how you're able to move your arm. It extends it. This is why this makes a hook. That's what's going to allow you to extend your arm. You have one more fossa here. So you have the radial fossa, which you can see right here. So the reason is the radius has a radial knob-like head. So you can always remember radius because radius has a knob on the end, kind of like this, and it looks like a radial knob. So radius, radio. So when you push your arm all the way to each other, and essentially you flex your arm, the head of the radius has to have a place to kind of go because it's rounded. So this radial fossa is going to allow for the radius to kind of have a pocket to go into when you bring your humerus and your humerus and your radius close together, just like this. So if you take your arm and move it very, very close to your body, that head of that radius right here has to have a place to, or a pocket to kind of go into. If not, it would stop your arm from completing going into each other. Just like your ulna. Your ulna has a coracoid process and a coronoid process and a olecranon process. If it did not have a pocket, you would not be able to extend your arm all the way or be able to contract it all the way. So here we can actually see the ulna. So the top portion, or the biggest portion of the hook, is actually the olecranon. So this part right here at the very base, so this is the olecranon process. This is the coracoid process. Those two processes, remember, they're sticky outy things. That's what's going to essentially articulate with those fossas. Those fossas allow a pocket for these hooks or these very sharp pieces to go into so that you can bend your arm. I explain a little bit better in my lab videos. At the end of the radius and the ulna, you have a styloid process. So if you look closely here, it looks like a little stylus. It looks like something that you could actually tap on a screen with. It is a very point that is going to be at the ends of your long bones. Now, when we are in anatomical position, our arms are spread out like this, facing us, right? However, if you take your arm and switch it and flip it over, so if you went from this to this, your radius and ulna actually cross over. So if you held your hand like this versus doing it like this, you actually cause your arm, your radius ulna to flip. So actually take your hand, place it on your arm, and then flip your hand over. So take it like this, flip it over, and you can actually feel those bones crossing each other. So that's why we stand in anatomical position. We make sure our hands are in the prone position. But if you switch it over where you can see the back of your hands, that's actually turning your bones over so you can't actually see it. So another fun fact is if you like chicken wings, the radius and ulna, if you like the flats of chicken wings, you're actually eating the meat or the skeletal tissue off of the radius and their ulna. And if you like the drums, you're actually eating the meat off the humerus. Just a fun fact. All right, so probably one of the best parts of learning about the bones is how to do the hand. So each bone in the hand has a name, and it's actually pretty simple. So if you count with your hands. So if you use your thumb to start with number 1, your index finger for number 2, if you go from 1, 2, 3, 4, and 5, that is actually how you count. So start with your 1, 2, 3, 4, and 5. So we can see here your thumb would be 1, index 2, this is your 3, 4th, and 5th finger. So these bones here at the very base of your hand is going to be your metacarpals. Now your wrist bones are your carpals. So if you ever heard of carpal tunnel, it's usually because there's a fascia or a ligament in their hand, in their wrist, that compresses on that nerve. That's how you can always remember carpal, is because of carpal tunnel. So carpals are referring to your wrist bones. Metacarpals are the next long bones that are up here. So if you make a fist, your knuckles are the distal ends of your metacarpals. So when you make a fist, those knuckles are your metacarpals. Now, for your second, third, fourth, and fifth fingers, you have a proximal as well as your thumb. So all these have a proximal. So here's your proximal 1, proximal 2, proximal 3, proximal 4, proximal 5. On your phalanges, you have a middle, what's called a middle phalanx or middle phalange. So that's here you have proximal, middle, and distal. So this would be proximal number 2. This would be middle number 2. This would be distal number 2. And that is the same for all these 4 fingers here. On your thumb and on your big toe, you do not have a middle. You just have a distal, a proximal and a distal. Look at the palms of your hands. If you notice that there's these lines that separate these bones. So if you want to look at your hand as your own reference while you're taking the test, I invite you to do so. Each one of those lines are going to be the separation between your bones. So if you look at mine, you see that there is 1, 2, 3. So you see 1, 2, 3. So here's my proximal, my middle, and my distal. So you can actually use your own hand as a reference. But remember, on my thumb, there's only a proximal and a distal. There is no middle. It's just a proximal and a distal. So if I were to say find finger or proximal number 4, so here's your proximal on your 4th finger. So you'd go 1, 2, 3, 4 on the 4th finger. Your proximal is right after your metacarpal. This is proximal number 4. If I said distal number 3, well, you go to your 3rd finger. Distal is at the very ends, of course. This is your distal number 3. If I said distal number 1, remember 1 is your thumb. Distal would be the furthest one away, so this would be your distal number 1. That was pretty simple. That was our hand. That's how we name the bones of our hands. They're really not names per se. They're actually really numbers more than anything. So like metacarpal number 3, this would be this one right here. So if you can remember to count 1, 2, 3, 4, 5 with your hand, starting with your thumb, one being your thumb, and 5 being your pinky, you can actually count which fingers are which. The carpals, they all have their names. So your wrist isn't just one bone, it's actually made up of several. So you have the scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and hamate. A mnemonic that you can use to remember these is that some lovers try positions that they can't handle. So some would stand for scaphoid, lunate for lovers, tri for triquetrum, try positions, position being pisiform, that they would be trapezium and trapezoid, cant would be capitate, and then handle would be hamate. So that's a simple way for you to remember the carpal bones. There's some lovers try positions that they can't handle. Typically, the bones that are going to get hurt the most if you were to fall is going to be the scaphoid and the lunate, just because those are the ones that are essentially articulating with the ulna and the radius. So if you fall on your hand, those are going to be the most prominent bones that are going to get essentially injured. So the pelvis is actually quite a few bones put together. So we think of this pelvis, when we say the pelvis, it's actually all these bones put together, but it's the coccyx, it's the sacrum, it's the os coccyx. Um, and the os coccyx are actually is three bones actually put together. So here we take a look at the pelvis. We have what's called the ilium. So that's the bone that's right here. That's the big broad bone right here. This is also a fossa. So this is the iliac fossa. This is a thin ridge, which is also called a crest. This is on the iliac bone or the ilium bone. So we call it our iliac crest. So that's when you say you put your hands on your hip. This is what you're actually putting your hands on. Pubis, just like the pubis area or the pubic area, this bone is a very pointy bone. So we always remember pointy pubis. That's how you can remember pubis. And then you have ischium, which is the part that you're actually probably sitting on right now. When you're sitting down in a chair or sitting in your bed, you're actually sitting on the ischium. The way that I remember that one is because if you don't wash your butt, it's going to itch, and it sounds like itchy, or it sounds like ischium. So that's how I've always remembered ischium is what you're sitting on. Pubis is pointy, which is this very pointy portion right here where your pubes are. Ischium is what you're sitting on, and then ilium is what you put your hand on, is your iliac crest. The hole or the socket that you actually put that the femur head actually articulates with. So this portion right here this little portion that I'm actually sticking my finger in, this portion here is actually referred to as the acetabulum, or how I like to pronounce it is acetabulum. It is the socket that the head of the femur actually goes into. Now, once we actually look at the os coccyx, here you can actually see how the coxal bone is broken down into three different bones. So they're fused bones. So you have the ilium at the top, the ischium, which is the part that you sit on, and then the pubis, which we can see here that's pointy. Those are the three bones that make up the coxal bone. And we can kind of give a better representation here. So here we can see we have the iliac crest, which is what you put your hand on. These notches right here. So we can see this big notch, which is called the greater sciatic notch. Down here, we have the lesser sciatic notch. You may have recognized this word before, sciatic, or like sciatica. There is a grand nerve that runs down your leg, which is the largest nerve of your body, really. It comes from the lumbar portion of your body, but it runs along these notches. Ergo, the name sciatic notch. The sciatic nerve is responsible for carrying most of your nerves to your back, or I mean to your leg. So if you have lumbar pain or you're having issues with the lumbar portion of your back, it can cause what's called sciatica or issues with the sciatic nerve. That nerve can cause a lot of leg pain and cramps and tingling if you mess with that nerve that runs through here. Here we have a really big hole, kind of like the base of our skull. This is called the obturator foramen. You can remember obturator it sounds like operator. So if you take your coxal bone and hold it up to your ear, it almost looks like a phone, like you're dialing the operator. So this would be obturator foramen. And then here we can actually see the acetobulum, which is the socket that our head of the femur is going to articulate with. On this side, we can see that we have an iliac fossa, which is what a muscle is going to sit in. So remember, there's muscles covering all of these bones, but some muscles kind of have essentially like a little spot that they lay in. And this one here is the iliac fossa. Then here you have the pubic tubercle, which remember a tubercle is a small, rounded, rough portion of the pubis. So here we can see how the pubis is actually pointy. So that's how you can always remember pubis is pointy. And then the ischium is the part that you sit on. And here are the bones of the lower limb. So here is your femur. Your femur is your strongest bone of your body. This bone can actually balance an elephant. It is that strong. It is legit the strongest bone of your body. Now, there are some particular landmarks like the greater trochanter and lesser trochanter. The greater trochanter and lesser trochanter are only found on the actual femur. They're not found on any other bone. They are responsible for attaching ligaments and other things. You can kind of see the linea aspera, which is going to allow for different connective tissues to connect to the bone, which is this very long line that's running down the femur here. Here we can see the head. So if there's a head, there's a neck, just like us. We have what's called a fovea, which is a small little divot. It's this very small little pocket that's going to allow for a ligament to attach the head of the femur to the acetabulum. So it's essentially it's almost like a little rubber band that's going to attach right here in this fovea into the actual acetabulum, which is going to help keep that femur attached to the coxal bone, because we don't want to dislocate the coxal bone or the femur. We want to make sure that the femur and the coxal bone are nicely secured together. So it kind of acts like a little rubber band that's attached at the fovea and then attaches to the acetabulum. Now, at the base, we have a condyle, which is what I first showed you, which is that very smooth, rounded oval portion. So this bone here is going to articulate with the tibia, the tibia is your shin, which we'll get to in a second. The way that you can know that you're looking at the front or back of the tibia or of the femur is because the front of it, which is what you see here, is flat. The very front of it's flat. Just like this, it's very flat. But if you turn it to the back, you see that it kind of has like a little booty. So essentially, the booty's in the back, it's flat in the front. So if you can see this portion, which is the butt, you're looking at the back of the femur. If you see this portion here, which is flat, this is the front, kind of like me. It's flat in the front, and then you got a butt in the back. So this is how you can tell whether you're looking left or right. So kind of just like your humerus, where you stick your thumb out and it's pointing the direction. Remember, everything points towards the midline. So if you stick your arms out and you stick your thumb out and you look at how the head is sticking, the head is pointing to the left. So if you stick out our right arm and we use our thumb as the head, that is going to be our right femur. And then in vice versa, if you had a left femur, it'd be pointing to the right, and we stick out our left arm, The head of the femur would be our thumb. This would be our left femur. And then next down is our tibia and fibula. Make sure not to say fibia, it's fibula. So the tibia is going to be the bone that's going to run, that's going to essentially make our shin. That's right there is the bone, that's the long bone that's right above our foot. That goes up to the bottom of our knee. That is the tibia. You can remember tibia because it kind of makes a T shaped here. You see that it makes a little bit of a T. This is our tibia. So if you like chicken bones or like to eat chicken legs, this is the bone that you're actually eating off of. So the tibia, you have a lateral condyle and a medial condyle. This is where the booty of the femur is going to actually attach or articulate with. The intercondylar eminence is where you're going to have your ACL and your PCL attach. Typically, we usually have a lot of issues with athletes when they tear this because usually there's two ligaments that make an X right here. Those two ligaments are going to essentially attach remember ligaments attach bone to bone, so it attaches the femur and the tibia together. However, sometimes with athletes, they can tear that ligament, and ligaments are avascular, which makes it very difficult for them to heal. So here we have a tibial tuberosity, which is a little bit of rough edge here, which is going to allow for ligaments and muscles to attach as well. The fibula, it's always going to be on the lateral side. Kind of think about it if you were walking with crutches. Remember, crutches are going to be to the lateral of you. The fibula gives stability to the tibia. Remember, the tibia is carrying all of your weight. So it needs to have something to help it stabilize. So that's why there is a fibula right beside it. At the end of the tibia, there is a styloid process, but it has its own name. It's referred to as the medial malleolus, which, if I can show you here, which is this portion right here on the end of the tibia. This part that looks like a little bitty hook like this, that is the styloid process, but that styloid process has its own name. It's the medial malleolus. It's always medial, so that's how you can tell whether this is left or right as well. The medial malleolus, so the fibula is going to be on the lateral portion. The malleolus is going to be on the medial portion. So this one, my hand would be the right one, just because I can tell where the malleolus is. So if you can always look at the malleolus, you can really tell which one is the right and the left. So for the feet follows the exact same rule numbering as the hand. So instead of your thumb being number one, your big toe would be number one. Your index toe would be number 2, 3, 4, and 5. So they follow the exact same rules as the hand does. Now, the ankle bones are not called carpals, they're called tarsals. In your hand, you have metacarpals, but in your feet, you have metatarsals. So the name changes, depends on where you're at. So in your hand, it's metacarpals and carpals. In your feet, it's tarsals and metatarsals. In your ankle is made up of a few bones as well, just like your wrist. So you have the calcaneus, which, if you remember from our regions, it's the calcaneal region, the talus, which is what the tibia is going to articulate with. And then you have a navicular, and you have a medial cuneiform, an intermediate cuneiform, a lateral cuneiform, and then a cuboid. These can be a little bit difficult to remember, but I have another mnemonic. You can remember tiger cubs need milk. but spell milk with a C. So tiger cubs, which would be Talus calcaneus, so that'd be tiger cubs. Need would be nuvicular. Milk, medial cuneiform, intermediate cuneiform, lateral cuneiform, and cuboid. So that would be your milk, would be your medial, intermediate, lateral, and cuboid. Instead of spelling milk with the K, spell it with the C. So tiger cubs need milk. So tiger cubs need MILC, milk. So in your foot, you should have an arch. I unfortunately do not. I have a flat foot. That just means that the ligaments on the bottom of your foot essentially have become loose and your weight has essentially pushed it down. I believe I was probably born this way. Sometimes people have to have corrective surgery because it can cause issues or foot pain over long periods of time. I actually had a teacher who had to get his arch, essentially have surgery on his arch. They had to break his foot, break break bones in his foot to essentially reset his arch. So sometimes you can get away with being flat-footed, sometimes you can't. But you actually have a ligament and a fascia and muscles that run underneath here. And sometimes if they get too irritated, it can make it very difficult to walk. And I have suffered from that when I was in college. The base of my left, actually my left foot, um, it fell essentially. The arch kind of fell, and those tissues that are underneath the bottom of my foot was very inflamed, and so all the weight was pushing down it. So I made it difficult for me to walk. I could not walk from here to my door of my room. Um, Essentially, I had to essentially be carried. So this can cause a lot of pain if it's not proper. Which I've been flat-footed all my life, but sometimes it has issues. So here's some different types of pathologies. So you can have a bunion, which essentially the joint has essentially become inflamed and causes pressure to push your toe to the left or the right. Here is pes planus, which means flat-footed, which mine is not that bad. Sometimes you can have too much of an arch in your foot, which is called pes cavus. You can be club-footed, which essentially causes, which is the kind of a deformity of your ankle bones and your metatarsals are going to essentially make it to where your foot is kind of in a club-like fashion, like a golf club kind of fashion. It's going to have a curvature. And then you can have stress fractures on your metatarsals, which essentially causes them to break. So here are some deformities that can happen um, with some limb malformations. So during development, remember our bones are essentially cartilage, and so sometimes there can be some things that happen. So sometimes you can have polydactyl, which means poly means many, which means essentially you have extra digits. So we've heard sometimes people can be born with 6 fingers. The way to get rid of that, essentially, they'll put like a tight rubber band around that 6 finger, and eventually it'll essentially pop off. You have extrodactyl, which is the absence of a digit. So instead of having 10, you have 9. You can have syndactyl, which is essentially webbing or abnormal fusion of the digits. So during our development, our fingers have this webbing on the inside of them. So you can think about like a duck's foot where it has webbing. All their toes are connected and looks like a one big foot. Our hands used to be like that, but during when we're developing in the womb, we go through apoptosis, which actually starts degrading that webbing between our fingers. Sometimes there are abnormalities or defects that stop that from happening. And so you're born with this webbing, you kind of like you have a flipper almost. Amelia is if you're missing a limb completely. So sometimes, especially like with Agent Orange, which was used during Vietnam days, it can cause children to be born with no limbs. There were certain medicines that actually caused limb deformities or to be born without limbs. Phocomelia, which refers to a short, poorly formed limb that looks like a fin of a fish or a flipper of a seal. Um, a medicine that was actually given back in the 1950s, which was given to women that was essentially a sleep aid. So essentially, they found out later that women that were taking this specific type of medicine was actually having children that were having deformities. So they were missing limbs, or essentially they were having many fingers. So it was causing a lot of these defects with their limbs. Either they were born without legs or arms, or they had more fingers and toes than they were supposed to. And so they were able to correlate it back to what's called thalidomide, tongue tire there. It was a medicine that was given for sleep purposes. They took it off the market for a while, and then they brought it back because they can use it to treat cancer for bone marrow cells. They can treat symptoms of AIDS and lupus, which is an autoimmune disease. However, even though that they have told people that this can be a really bad thing, people still go against their warnings and still take it. So, unfortunately, it is still on the shelves. Just be careful if you do plan on getting pregnant anytime soon, or you are pregnant, to stay away from this type of medicine or barbiturate, because it can cause deformities in development. All right, that's the end. I know it was long, but hope you learned something new, and we will see you next time.